This case is an example of lactational mastitis. A 28-year-old breastfeeding woman presents with unilateral breast pain, redness, and fever, and flu-like symptoms. There is no fluctuant mass or breast lump on examination. What is the most appropriate initial management? Stop breastfeeding, immediate surgical drainage, oral antifungal therapy, continue breastfeeding, and start oral antibiotics. Breast ultrasound only. The correct answer is continue breastfeeding and start oral antibiotics. So in this case, breastfeeding is a key finding here. Breastfeeding is very important as it is associated with two common disorders. Okay, breastfeeding can be associated with lactational mastitis, and also can be associated with breast abscess and lactational adenoma. So how to distinguish between lactational mastitis and breast abscess? Unilateral breast pain, if the patient presents with unilateral breast pain, redness, fever only, this is most likely to be mastitis. Inflammatory signs, inflammatory symptoms only, most likely to be only mastitis. If this is associated with breast lump, or on examination there is a fluctuant lump or a breast mass, this is most likely to be breast abscess. And if breast abscess is suspected on examination, then ultrasound should be performed, and if ultrasound confirmed breast abscess, then surgical drainage is the most next step of management, the most appropriate next step of management. If no fluctuant breast mass or lump, so lactational mastitis is the most likely diagnosis, and the most appropriate initial management is to start oral antibiotics and to continue breastfeeding. Don't stop breastfeeding, as stopping breastfeeding will worsen the milk stasis and will lead to more inflammation, more mastitis, because they will worsen the milk stasis. Okay, so the explanation: lactational mastitis is usually caused by Staph aureus, Staphylococcus aureus. As you know, Staph aureus usually present on the skin of the breast, and with lactation, the breast may be inflamed, and the Staph aureus can be transmitted into or through the injured breast by lactation and causes lactational mastitis. So Staph aureus is the most common organism to cause lactational mastitis. Management of lactational mastitis includes to continue milk drainage. Okay, try to continue milk drainage. Try to decrease milk stasis. Okay, this is very important for management of lactational mastitis. And oral antibiotics. Okay, Stopping breastfeeding may worsen the milk stasis. Stopping breastfeeding can exacerbate infection. It will worsen the breast mastitis, lactational mastitis. Surgical drainage is only if abscess is suspected on examination and confirmed on ultrasound. So surgical drainage is performed only if abscess is confirmed on ultrasound. Antifungals are inappropriate. Okay. Ultrasound is reserved if abscess suspected on examination. If there is a palpable breast lump, so abscess will be suspected. If suspected on examination, ultrasound should be performed. I will show you a case of breast abscess. This patient, let's make it, a 34-year-old lactational or lactating woman. So this is a lactating woman. There is history of lactation with erythema. And erythema makes you suspect lactational mastitis. Okay? However, the swelling makes you suspect, the swelling makes you suspect breast abscess. Tenderness of the breast of 9 days duration makes you suspect the development of breast abscess. So this is not simple mastitis. Okay? Swelling and tenderness for 9 days duration makes in a lactating woman makes breast abscess is the most likely diagnosis. So from the examination, abscess is suspected. Then I will recommend ultrasound scan. Sonogram in the transverse plane shows a complex cystic and solid mass with hypoechoic debris and a thick wall, complex cystic. It is not a simple cyst. Okay, so ultrasound demonstrates a complex cystic lesion. Why complex? Because there is no signs of simple cyst. What are the signs of a simple cyst? This is an example of a simple breast cyst on ultrasound. Okay, clear content, anechoic, it's very black. Anechoic content. Okay, look at the wall here. Thin-walled with posterior acoustic enhancement. Can you see the enhancement here? Posterior acoustic enhancement, thin-walled anechoic cyst. Then compare with this one. This cyst is not anechoic. It is the content of this cyst is not clear, content. Okay. It's the content of this cyst is debris. It's called debris. Sorry. So the cyst has hypoechoic content. Okay, hypoechoic debris and thick wall. This cyst has thick wall. This cyst is a thick-walled cyst with a hypoechoic debris. You can say with echogenic debris. Echogenic content, most likely debris. Echogenic debris, okay? Thick-walled cyst with echogenic debris equals complex cystic lesion. Complex cystic lesion. It's not a simple cyst. It's complex cystic lesion. So this is most likely to be breast abscess. So ultrasound in the transverse plane shows a complex cystic lesion with hypoechoic debris and thick wall, okay? So the key imaging finding, complex cystic and solid mass. Most likely diagnosis is abscess. A breast abscess is most commonly seen in postpartum and lactating women. Breast abscess is most commonly seen in a lactating woman as a complication of mastitis. At ultrasound or at sonography, a complex fluid collection is present consisting of echogenic debris, maybe internal septation, maybe thick-walled hypoechoic debris, maybe adherent to the wall of the collection. The cyst contains internal echoes that may float during examination. Internal echoes that may float during examination. These internal echoes may float. Okay. Differential diagnosis, cystic neoplasm, or hematoma. Differential diagnosis is hematoma, okay? And cystic neoplasm. Maybe fat necrosis, okay? The diagnosis here is abscess. So the treatment of abscess, ultrasound guided percutaneous aspiration for cytologic analysis as well as abscess drainage. So this is the treatment. Ultrasound guided percutaneous aspiration for cytologic analysis as well as breast drainage.